Halfwerk, assistant professor and principal investigator of the Cardiac Surgery Innovation Lab, with the presentation MiECC Principle to Change Conventional Extracorporeal Circulation Practice through Simulation-Based Training. Please, Professor.
Thank you, Dr. Condello, for the introduction, and Kalimera to all participants at the anniversary meeting in Thessaloniki, and obviously congratulations to the Society. It's an honor to be here with you. I have a potential conflict of interest in that I'm appreciative of a conference travel grant from Mackay to present the trial results at the Cardiac Surgery Conference, and I would like to disclose that I'm an associate member of the scientific committee of the Society for Simulation in Europe, and I'm also a member of EURELSO's Simulation Working Group. So we celebrate a decade of MiECCs to promote research and application of minimal invasive extracorporeal circulation. But we have to acknowledge that the widespread adoption of MiECC seemed to face many barriers. And one reason could be the evidence, are the benefits unknown to the community, or do people feel there is conflicting evidence when comparing MiECC to state-of-the-art practice, for instance, advanced extracorporeal circulation, I'll talk about it later, or off-pump coronary artery bypass use in high volume and high expertise centers. And when trials show statistically significant numbers, are they also clinically relevant to patients? Moreover, a long learning curve, patients at risk during this learning curve, where we should not accept a non-inferiority endpoint when changing local practice. And there's the aspect of dedicated teams, which is problematic when people relocate or get ill. So the question is how to move forward. There are many best practices available in established high-volume MiECC centers, but how to bring these conventional extracorporeal circulation centers forward? Well, the first option is to implement MiECC in those centers. However, still have to overcome the aforementioned barriers. Another option is to implement MiECC-like practice, for instance, with these advanced extracorporeal circulation circuit systems and practice. And in a randomized controlled trial, we compared MiECC with these advanced extracorporeal circulation systems, or type 2 versus a type 4-like system with a centrifugal pump, soft shell reservoir, a fully coated system, cell-safe use. And we found no difference in our clinical endpoints, so no difference in MACE, mortality, transfusions, and length of stay, proving that might be a great alternative for some conventional centers. And we know that MiECC is more than just downsizing. It's not only about circuit optimization, it's also about team optimization. This was stretched out yesterday by Professor Anastasiadis as well. And I feel that simulation-based training might help to overcome the aforementioned barriers. Well, simulation-based training helps to advance knowledge, for instance, principles of cardiopulmonary bypass, about the difference between MiECC and conventional systems. It's about improving technical skills, such as surgical skills, which can be basic or advanced. It can be about surgical handling. It can be about cannulation, for instance, peripheral cannulation for the use of MiECC for minimally invasive cardiac surgery. But simulation-based training is also about non-technical skills, about crew resource management, about team training, to reduce human error with improving situational awareness, teamwork, leadership, and decision-making, also known as the non-technical skills for surgeons. How effective is simulation-based training? Well, you can assess the effectiveness on 4 levels, the Kirkpatrick levels. So the first one is reaction. Do people like the training that is offered? The second level is about learning. Does knowledge, technical skills, or confidence actually improve? The third level is about behavior. Is the behavior that is trained also applied during daily practice? And the fourth level is on, do patient outcomes actually improve? And unfortunately, studies regarding the effectiveness of simulation-based training on patient outcomes are rarely conducted. Next to MiECC, simulation-based training also has perceived barriers. And in this more than 20-year-old paper We see examples of drill types of crisis management exercises, oxygenator problems, pump failure, air embolism. And reasons for not doing this simulation-based training is the individual responsibility, it's the motivation to do so, but also a lack of confidence in their own proficiency and a lack of expertise. Well, we do know that simulation-based training for cardiac surgery is effective. For instance, on anesthesiologists, non-technical skills, they improved compared before and after simulation-based training. Also, they were better than regular seminars and regular lectures. You can also use simulation-based training to state the importance of critical events checklists, for instance, during cardiopulmonary bypass. And if we look at behavioral outcomes, we know that if you follow the EACS endoscopic mitral valve course, 1/3 of the participants reported to start minimal invasive mitral valve surgery program, and showing an actual behavior change in practice. And if you look more closely to our practice, we look at the effectiveness of multidisciplinary cardiac surgery team training. It proves to improve surgeon communication, but not only that, also for the anesthesiologist, the perfusionist, and the team as a whole, showing these domains of the non-technical skills for surgeons. And often when we talk about simulation-based training, the term of high fidelity comes into play. But what is it? What is fidelity? Well, fidelity is about the realism, about simulation, about the simulator. It's not a quality mark. So a low fidelity simulator might be useful for novice learning. So for instance, learning suturing skills on a banana is feasible for graduate students. And high fidelity is extremely complex. And the question is, how can you assess this fidelity levels? And we developed a framework to assess fidelity of many simulators. And if you look at the previous used simulator, in this case, the Orpheus perfusion simulator, but look closely at the fidelity aspect, we will define it as mid-fidelity. And actually, there are no high-fidelity simulators available related to cardiopulmonary bypass or ECMO use. So how to move forward for MiECC? Well, I think there are a lot of relevant scenarios to improve decision-making. Great examples already exist for scenarios regarding, for instance, air embolism. But the question is the problem communicated adequately to the team, to the perfusion team, anesthesiology team? Is there a correct response? Is the patient put in Trendelenburg? Are the cannulas cleansed? How is the debriefing? Is there safe communication? So I feel that there's enormous potential for MiECC. So I feel the future of MiECC or MiECC-like practice is to train before actual practice on patients. And I foresee a new dogma for heart surgery. See one, simulate one, do one, and teach one. And with that, to decrease MiECC learning curve and remove barriers to MiECC or MiECC-like practice. But we have to develop MiECC simulation-based training. And the question is, what do we need? We have to conduct training needs analysis. Which aspects of MiECC practice do we aim to improve? And how to assess the impact of simulation-based training on MiECC. And we have to use the expertise that's available in societies. EACS is building up expertise with the Society of Simulation in Europe, but also Euro elsewhere where expertise is available. So for me, this is the future of MiECC-like practice, the way forward with simulation-based training. And with that, I'd like to thank you for your attention, and I'm open for discussion.
Thank you so much, Professor, for this impressive presentation about the training. I believe that is the future of perfusion in all aspects and in all procedure. There is the question from the audience or our panelists, please. No, I have a question for you. Do you think that in the context of MiECC, in the multidisciplinary approach, not only for the perfusionists, improve the technical skills, in particular in the management of the volume of the accident during the MiECC procedure, in your experience?
Yeah, I think MiECC is maybe one of the best examples of team training, where the balance for patient safety, the essentials are in team efforts, and I think the whole team should be trained. So not only on these technical aspects, how to handle from the perfusionist side, but also on volume management sides, the position, etc. But also on communication. So are the problems perceived, communicated? And I feel simulation-based training is the way forward to train teams adequately for emergency situations and for MiECC as general training. Absolutely, yeah.
Thank you, Professor. If there aren't, okay, from Michael Vandriel, please, you come. Yeah.
I'm afraid I cannot hear the question.
Yes. Will arrive. It's a problem of microphone.
Okay.
Yeah. You come from the podium, no problem, please.
All the way from the Netherlands.
Yeah. Good morning. Can you guys hear me? Oh, perfect. Okay. Hey, there was Frank. Thanks for that presentation. I think maybe one thing to add to this is that the difficulty with simulation is always training the entire team. But what we have seen that's been effective is at least using some of the training equipment that's already available on the market, like Califia is a good example. In the absence of being able to find a successful way, short of actually doing an animal, to be able to train the entire team on mini bypass or with MiECC, honestly, there are other technologies available that are not a bad substitute, especially for emergency training. I just wanted to maybe get your perspective on that kind of technology, but also what else needs to be done beyond that, beyond the technology that we have now. What else would we need? Thank you.
Absolutely a valid point. So I would say two aspects. So I talked about low fidelity, mid fidelity, high fidelity, and I feel that for several aspects of first getting the knowledge right of the, let's say, everyone in the team, you can do it individually. You can train the skills individually. You can scale up going to more complex situations in the OR, in a simulated operating theater. And I think in the end, we have to get teams together. If you want to perform MiECC, if you want to perform high-level surgery, simulation-based training is just as important as doing a timeout, right? So we have to allocate time. The question is how to do it. It goes beyond this talk. We assessed 30 simulators, Califia as well, other ones. I feel there's a need to make a high-fidelity simulator to be able to simulate all aspects of MiECC or cardiac surgery in general, which is not really out at the moment. There are simulators available for a lot of components, fully agree. But I think we have to develop this. And there's a disclosure from my side that we are developing such a high fidelity simulator at our university at this moment. Yeah.
Thank you very much again. Thanks, Frank. For the sake of time, I think we'll move right into the next session here, which will be from comics to MiECCs. And I'll let Dr. Merkin and Dr. Anastassiadis come up and moderate those.